Okay, hi again. All right, I believe you can see my screen as well. All right, based on the pandemic situation, so what are types of the differentials? The differentials of the media use and how to get access to the information. As media use and the communication inequality in a public and health emergency. So at a glance in the swine flu in the pandemic situation. So there's also the swine flu means the swine means the pig, right? So you may remember that I asked whether the swine flu caused by the eating pork or not. So based on that, the differences of the exposure to the public health the measure messages and the capacity to access, the ability to access and the process and act upon the information received, that will make the differences, right? So it's not merely about the owning the phone or having the internet. It's about whether the message is built for educated, connected, and the majority language audiences can be encountered and understood and trusted and acted on. So let's say that those who are less educated and they are not connected and the mother tongue is not English. So they may have the less accessibility to the information, very important information during the pandemic. So very fast, very, very fast, and the move and the actions and the responses were very important in the early stages of the pandemic situation. Like move away from the very dense area and getting the vaccination and the social distancing and the personal hygiene on the strategies. These are very important at the first time with the first exposure and the early stages of the pandemic situation. But these are usually gained based on the education and their accessibility to the information as well. So these are the survey on the information. So maybe we don't need to focus on that. But because of the officials, the concrete misconception happened at the first time. Because officials at the WHO first called PH1N1 the swine flu, some people avoid eating pork on ineffective behavior the virus thing itself produced. And their misconceptions are about everyday confusion and uncertainty, not social media conspiracy theories about that. So SES, there are key findings as well. The SES shapes the invisible information pipeline. So if we have the high socioeconomic status, we may have the fewer barriers to accessing the processing information. So you may own the good levels of education, very enough levels of education to interpret the very important types of the access to educate the information and more accurate PH1N1 knowledge and fewer misconceptions. And in opposite, lower SES faced more barriers. And knowledge drives behavior both ways. And more knowledge was associated with the positive with adapting recommended measures, hand washing, distancing, and negatively with adapting incorrect ones. In opposite way, the low knowledge would mean then very ineffective ways of the strategies, like not eating pork. Not eating pork is not work a lot for the H1N1 and the swine flu situation. And information engagement it protects. So people with the higher assets, higher news exposure, and active information seeking were less likely to adopt incorrect prevention behaviors, and then their counterparts would be very, very important findings as well. All right, so why universal messaging is not equal? So the government and the relevant body of the government, they will send the messages as an alarm. So all the people, okay, so notification. So these are not equal. The universal messaging would not be very, very equal. So government announced on TV looks like it reaches everyone. So they might be relevant with very universal access to the people. However, these are not unequal. No, sorry about that. These are unequal because we can trace down those differences. Access. Can you reach the messages? Yeah, but if they do not have the literacy, like in the illiterate, and if they have the disability, they may not see the messages as well. Can you understand and evaluate it? And can you trust that source? And can you follow the advice? So that will all impact on the situation. We can know that. So the groups in the most in the need of accurate health information are the least likely to receive, understand, trust, and be able to act on. So that's the irony we can see, right? So those who are vulnerable to the risks, they must have the very good chance of the understand or that they would have. So I cannot blame the who that would not trust the scientific method of the system. But anyway, these are some types of the mechanisms we would understand. All right, so that's about that. And based on the Shannon, Abraham, and the Beckwell, Adams, and the Howard racial disparities for the COVID-19 mortality in Georgia, based on analysis by age based on the excess of deaths. All right, so why excess deaths? The excess of the deaths are the deaths above the historical baseline based on the area, right? Maybe I can change it. Okay. So the ARIMA outlier detection and the 95 historical confidence intervals, black to white risk, and they found that they confirmed the COVID-19 deaths is undercount because testing was scarce and especially early. And there were more deaths at home often. They were uncounted by the COVID-19, and communities with less testing were uncounted the most, right? That's the opposite direction of the findings. So we would see that. Oh, why? The why are there the excess of the tests? Because there were the less number of the tests, and that was not because of the low number of the tests, but these were undercounted numbers of the tests in those areas. So the disparity widened at the end of life. In the older ages, there were more types of the disability in that. So disparity in age is specific, and striking gaps are among the children and among adults. Among children and among adults, especially for the COVID-19. Right. So children under 18 years old before the adulthood all-cause mortality fell for both groups in 2020. Lockdown shelter in place, but it fell far more steeply for white children. So the black and white risk ratio rose in the 8 of the 10 districts in the Georgia area. So there are more and more disparity between whites and the African American. And older adults more than 65 years. Before the pandemic, black older adults had mortality, lower mortality than whites. There are many of the selection bias and other mechanisms as well, but based on the pure statistics and the number, they have the lower mortality than the white after 65 years old. So it means that those who are weak, combined with the Johnson joke, those who are weak, they already passed away before 65. So those who survived after 65 in African American, they were very healthy. But in 2020, this reversed. Black mortality rose far more. The pushing risk ratio above 1 across nearly all the whole state because African Americans were living in the more multi-generational residential area, residence in the household, and they may have the lack of the social infrastructure, and they may not have the good trust to the on the healthcare system because of the many of the historical events in the United States area. So the children under 18 years old and the older adults after over 65 and under the 65 and older, they were more vulnerable to the risks of the COVID-19. And the rate rose moderately for the black adults, and there were less dramatic of the three age blind bands. So what it shows, the author's interpretation of the social determinants of the health condition. So based on that, the children, White House were better, essential workers, the Black Georgians are overrepresented in the high exposure, low wage jobs without the telework or the remote work options. So the essential workers were more filled with the people of the color, and then they would have the more exposure to the infectious disease we learned in the previous article. And all the others in the commodities and the weaker healthcare access and greater exposure plausibly drove the reversal and the black-white ratio, and especially for the COVID-19, and they were more striking for the older adults. and they were concentrated in the early hotspots. Metro Atlanta and the Southwest Georgia has a high density, and there are more exposure of the COVID-19. But read the limit carefully about this article. So this is more about this creative. It's not about the causality. And the essential workers place drawn from the discussion decided literature is not plausible knowledge literature tested. So there are the limitations. However, they try to find the disparities, disparity widen in the early life stages and the or the other stages. And Hardy and paper number four, right? Paper number four, Hardy et al. And who is blamed for COVID-19? Politicized fear and the health behavior in the United States. All right, so who is to blame for COVID-19? Yeah, I'm glad. I'm glad to cover this section. So, and also I'm very careful with the cover this section because maybe if we were covering this in the classroom, probably we might have some kind of more careful about that. But anyway, so we are not seeing anyone each other, so maybe we are free from the seeing each other based on the race. So political ideology drove public action in year one of the pandemic situation, the 2020. And the team asked that anxiety, fear, and blame differed. Overall, over the political device, we can see that. All right, so for blame landed, the right-leaning center or the more conservative the respondents, they were they blamed the China and the cultural practices of the people, and the left-leaning and the more liberal, they were trying to criticize the government and the Trump and the capitalism, a neoliberal economic system. So the perceptions are very different. We're not sure. We're not sure about that. But anyway, the blames diverge is getting wider, wider. The gaps are going wider and wider, and the mistrust is shared for the government and the vaccination. All right. So the left, the far left, I mean the more liberals, they were more likely to have the mask wearing and the public distance, social distancing, and the vaccination. And the conservative reported the higher sense of the national coherence and lower anxiety. They didn't worry a lot compared to relatively compared with the liberal others. So that happened in South Korea as well, and I'm not sure about the other countries, but in the US and South Korea, there was very similar outcomes as well. And there were no significant differences between the groups of the trust of the federal government. So in my articles, I also have the article, published the article regarding the vaccination. And in my findings, there were some differences based on their political orientation, but in their findings, no. So, across the entire political spectrum, people share the mistrust of the powerful elites and big businesses and the economic inequality, rational rate capitalism, and the neoliberal one. But who are the blame? Where they place the blame, not whether they fear the consent of power. So, based on their political orientation, there are many differentials of the health behavior. I mean, the protection from the disease and who are to blame. So xenophobia and the anti-Asian racism happens a lot in during the COVID-19. So as an Asian that lived in the US during the COVID-19, yeah, I was in the sometimes yeah, I felt very unsafe. I felt very unsafe in the metropolitan area because 2020 I graduated my degree for my PhD in the Maryland area, which is the suburb of the Washington D.C. And for my first job in the fall of 2020, I went to the very rural area because there was the rural Pennsylvania, and I felt much better because they had the lower the density of the urban area like that. So that they found that there were based on the findings, there were very highly increased the levels of the on the anti-Asian crimes, the Asian Pacific Islander people in the one. So fuel the cultural essentialism, the linking the virus, the eating bats, and the political system of the Wuhan coronavirus. There were more debates about that. So on there are the racially the blames and the social harm that accompanies the biological one, hate crimes and the discriminating. So this is not measure that Asian Americans avoided testing or care, but there were some of the minority members, they were more likely to be blamed and they were more likely in the endangered because of the system. All right, so based on those summaries of the articles, those three mechanisms of the epidemic inequality, differential exposure, differential capacity to the act, and differential willingness of the act. So who meets the pathogen is set to the occupation, housing density, transit methods, and the ability to distance before any of the individual choices made. So if they have the very, very high levels of the exposure, because of their socio-economic condition and other conditions, maybe they cannot make actions. So before they choose the capacity or action, they may be exposure might be a big determinant. But we cannot ignore the capacity and the willingness still. That even when information arrives, acting on it is unequal. Stay at home needs space, and on their for example, if they have the high education, probably, maybe they can have the better the availability of the remote work and get vaccinated needs of transport and time off. You may not. So in Korea, maybe, maybe you may not understand that. But like US or other the huge countries, they may drive through 30 hours. No, sorry about that. 30 minutes and 1 hour to the center that provide the vaccination. Yeah, I remember that there are the public because there were the vaccine centers because they had the lockdown of the system and the moving to the individual the clinics were not available. So we went to the some of the location. So sometimes these were the schools and they stopped the classes and they use the very big schools as the center of the vaccination. And if they do not have the car or the good ways of the public transportation, they could not come to there. And then that made a big differences. And different willingness would be met among those able to act in political context, share the willingness through blame and identity mistrust of the concentrated power. That would be a very big differences. All right. So for paper at a glance, the key findings are pandemic plans ignore social inequality. I forgot the one. WHO, the agenda, the pandemic plans ignore social inequality. Equity is a security issue. And H1N1, which one was the swine flu in the US, there are the SES, socioeconomic status differentials. So based on the knowledge, if they have the good levels of the knowledge, they are less likely. They would have the less likelihood of the apply or adopt incorrect on the behavior. And if that's the spatial knowledge of black-white gap, widen the among both the children and older adults. And then left adhered more and shared mistrust of the elites across the spectrum. So there might be understanding about that. So in South Korea, so South Korea is the very testable case of the differential exposure, right? So the hospital is shopping and they're the hiding the information, hiding the silence of the information, and the large crowded emergency room and family-based care is normal, so they kept the relative at the bedside. All that increased the exposure of the infection and the governance failure. As we learned about it in low time. I forgot there was a week 9 or 8, but the Ministry of Health delayed the releasing affected hospital names, cutting the public ability one. The communication-based inequality failure that fed panic and stigma. And then, because of this failure, the Korean case of COVID-19 was much, much stronger. So there were many of the double-edged sword because there were the positive activities and the negative aspects as well. So exposure of the occupation, many of the essential workers, they were more exposed to the risks of the COVID-19, and the migrant workers who are the manual workers and the elderly, older adults, and the politicization. These were also happening in the South Korea as well. So we can compare those activities as well. All right, so if we were in the classroom, maybe I would ask the question this as well. So using the three pathway model, exposure and the susceptibility, and what is the last one? And the third one, there was the act and the accessibility of the act and the behaviors as well. So how equitable was the current globally praised COVID-19 response as well? So you may remember that there were very strong, very strong strategies and the prevention and interventions in the COVID-19 situation in South Korea. And how those types of the findings we experienced, these might be impacting on the three steps of the exposure. Three pathway model. And then we can find those activities as well. So these are also the key vocabulary, and then you can focus on that. But yeah, so this time, one of the students mentioned that the using those types of the sample questions were very helpful for the preparation of the exam. So I tried to make it as a simple one, but these are not the exam level. So probably the exam questions are more difficult on that, but still I'm trying to provide the example about that. All right, so what are the single main ideas shared by all four readings this week? So again, this is just for the example, so very easy one, but trying to make the sense for you. Do you have a sense about that? So what is the single main idea shared by four readings of this week? An epidemic is a purely biological event unrelated to society. Oh, maybe. No, not very correct one, right? The parent who is harmed by the epidemic follows the lines of the social inequality. All right. The wealthy people always die more often during epidemics. Wealthy people die more. Once a vaccine exists, all health inequalities appear. Okay. Epidemics infect people completely at random. So which one is more likely to be answered? B. The virus is biological. The pathogen is biological. But who is exposed, who became because every ill, who can get care, and who is willing to protect themselves are all shaped by social conditions. Poverty, race, occupation, housing, and politics. So B would be the best answer. Too easy, right? A delivery worker can work from home, so he meets the virus more often than an office worker. So based on the Queen Kumar three pathway model on this, which of the pathway model? So differential exposure, differential susceptibility, and differential access to the care, differential communication, differential recovery. So maybe these are relatively indirectly related with about that, but what would be the best answer? Exposure, susceptibility, ability to care, communication, recovery. The communication does not mean that the disease, the communicable disease, like in that meaning. It's not meaning that. So that's why A would be the best answer. So exposure is not about who comes into contact with the pathogen. Right? So that's the key part. So that's why A would be the best answer. Susceptibility is about who gets severely ill once infected. So that's not better, the good answer. Access is about get tested and treated. And not a part of the clinical pathway model. So that's why the best answer would be A. In Shannon's et al., the jury just studied in which age group did the black-white COVID-19 mortality gap stand out the most? Infants only, children, and older adults. And young adults, middle age, the gap identical all the ages. Who would be answer? B. So as I mentioned, let's say, where are you? Where are you? No, 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 no. Sorry about that. Yeah, children and all the others that you could see. So that's why the best answer would be B, children and all the others. The best answer would be all the others. All right. So I tried my best to have the better understanding of the unequal exposure and the capacity and the possible pathways of the unequal the outcomes of the pandemic situation. So we already learned about the violence last week, and we will continue on the climate change in the week 13. All right, thank you very much for your attention, and I will add one more video about the AI supported AI supported in-class activity, but the lecture is done. Thank you very much, and see you in the next video, and see you in the class.